What do I need to know in assessing the patient to predict what kind of result that they'll get from their breast lift and what we need to do? One of the problems with breast lift, and why in fact the incidence of needing revisional surgery in breast lift is higher than in augmentation or reduction, is we're dealing with tissues that have stretched. The reason why this person is discussing their breasts and considering a lift is because the tissues have stretched out. And so as a surgeon, we're dealing with tissues that are generally more unstable than in some of the other breast conditions that we treat. Patients really do need to understand that. So when I examine a patient for a breast lift assessment, what I first of all want to know is their body history. Are they a massive weight loss patient? Did they get big during pregnancy? Examine their skin elasticity. Then I want to feel the thickness of the breast tissue that they have above the nipple and below the nipple, and work out exactly where the base of the breast is. Then I want to understand, and this is really important, the density or viscosity of the natural breast tissue. So if the breast tissue itself is watery and really soft and unsupported, then in general the risk of that re-sagging is higher. If somebody has quite dense breast tissue, so the breast has dropped, but the breast tissue is kind of firm, then the results of breast tissue are simply better in those patients. In the people with really soft breast tissue, virtually all of them will need implants to achieve a good result. And in the patient with good density of their breast tissue, they may need implants depending on how they want their upper pole to look, but they may not need implants depending on their own aims and goals. So the assessment's really critical. The history of the person's breast and body to that age and stage is very important. General health issues and the like, along with all the general assessments that we would do of the person's medical history and breast cancer risk, for example. Once the examination and the history is complete, I can give you a good guide as to what kind of operation we need to be doing and what's a reasonable expectation of the result that you could achieve, and also what kind of procedure is going to be necessary, both to elevate the breast mound, to use an implant if we need to and where that should go and what size it should be, to predict the nipple position, and mostly in breast lift we'll put the nipple 1 or 2 centimetres higher than its final predicted position because it will usually drop to an extent, and then how the lower pole skin excess is managed, whether it's through a lollipop type of incision or through an anchor pattern incision. Mostly some lower pole skin needs to be removed. All this planning is done in the office, it's not done in the operating room. In the operating room it's adjusted to an extent according to what we need to do. So typically if I'm using an implant, I'll put an implant in first, close that, and then we'll do the parenchymal adjustment based on how the skin is behaving with the stretch of the implant underneath it. And I'll check the predicted nipple position and check the lower pole resection. I won't do a final plan of those until the implant's in, so that I can be sure that the right amount's taken. The variety of procedures used in breast lifting is a number of them, from auto-augmentation to parenchymal pillar resection to a vertical only, to a vertical plus some horizontal resection, to liposuction around the edges of the breast, and various methods of reducing or changing the nipple and areola position. These plans are all made beforehand, confirmed in the theatre once the implants are in, if we're using implants, and then carried out neatly. So the whole process of breast lift is a long one, from assessment in the office, careful planning, patient education, and a careful procedure. And I also will predict for you before the surgery the chances of needing a further surgery. There's just some kinds of people that I know are going to stretch and drop and loosen to an extent, and typically if that's the case, then an adjustment in amount of lower pole tissue present and possibly an adjustment in nipple position may be necessary. And if that's the case, it's usually pretty straightforward to do, but I want to give you a guide as to whether that's a likely event for you or whether it's a very unlikely event.